Hello, thank you all for coming today for my talk on depression and dementia in older adults. My name is Brandon Rivard. I'm a physician assistant at the Center for Older Adults at York Hospital. Our office is located in South Berwick. And I also work for the Older Adult House Calls Department at York Hospital. I often discuss depression with many of my patients after we've completed a comprehensive geriatric evaluation. And just as an aside, please save your questions to the end, and if we want them to be recorded, we'll just hand around a little microphone to you at the end. I have nothing to disclose. I'd like to first start by talking about the definitions of dementia and mild cognitive impairment. Dementia is a state in which the person has some difficulty maintaining a previous level of function due to the changes in their thinking and memory. While mild cognitive impairment is a state in which the person has some perceived cognitive changes, but it's not affecting them in a negative way. Both of these diagnoses require that we rule out other things that could be ongoing. This is a very involved process that I don't really have time to discuss at depth today. And if you believe your memory or cognition is negatively impacted, please reach out to your provider. So what is depression? Many of you might know that feelings of sadness is the main symptom of depression. However, as providers, we frequently use this diagnostic criteria to help us diagnose. There's a helpful mnemonic that is often used to help us to remember the diagnostic criteria for depression, which is SIG-E-CAMPS. The S stands for sleep disturbance. This can be sleeping too little or too much. The I stands for loss of interest or pleasure in usual activities. Common experiences that patients will share with me in the clinic include, I used to write emails, play cards, listen to music, but I guess I'm just not doing that anymore. To me, these can be subtle clues that there might be depression at play because this person's not really enjoying their usual activities. G stands for excessive feelings of guilt or worthlessness. This could be related to having difficulty doing certain things that you used to always be able to do, and now you have to rely on others to help you to do those things. This loss of function can make one feel as though they're a burden, and will often feel guilty for taking time away from others. They can also feel more worthless as a result. E stands for decreased energy and increased fatigue. Feeling tired all the time is not always getting old. However, there are many medical reasons for which someone may have low energy, so it's important to discuss this with your medical provider. C stands for diminished ability to think or concentrate. Without being able to concentrate long enough, one cannot absorb the information and register it as memory. Many of my patients will tell me that they ask the same question over and over again, or they walk into a room and they forget why they went there for. These are not changes due to dementia. This is just a lack of focus over a period of time. In other words, you can't make a memory if you're not paying attention. You might as well have earmuffs on or be in the next room. A stands for appetite change with weight gain or loss. Something we might see is a change in diet as well. Maybe eating more junk food or not eating something you used to love to eat. M stands for mood is low most days. There's a common misconception that people with depression feel low all the time, all day long. The reality is that people with depression have good and bad days just like everyone else, but they often have more bad days than good days, and their bad days are really severe. P stands for psychomotor agitation or retardation. The retardation is a slowing of thought processes as well as slowed physical movements. The agitation component refers to unintentional and purposeless movements as a result of mental tension and anxiety, which could be why people with depression are often irritable or restless. S stands for suicidal ideation. Sometimes a subtle hint that someone is having thoughts of suicide is they're spending a lot of time planning and organizing their death. They may spend a lot of time getting their affairs in order and may start giving away prized possessions. Now, just because someone's working on a will or on advanced directives does not mean they're suicidal. This is a healthy practice that we encourage all patients to do at some point in their lives. You'll notice that some of these signs and symptoms are highlighted in red. These are the 4 symptoms that have been shown to be more profound in older adults than in younger adults. So now that we've talked about what depression can look like, let's spend a little bit more time to talk about how we diagnose it. We need 5 or more of these symptoms on the right over the same 2-week period. And it has to be a change from previous functioning. One note about this is that many older adults may have lived with depression throughout much of their lives, so they may not see that anything has been different over that 2-week period. It may have been gone on for so long that they don't notice anything's different. This is their norm. At least one of the symptoms is either depressed mood or loss of interest in doing things. That's the M and the I that I talked about earlier. And the symptoms cannot be due to another medical condition. This means if there is a reversible cause, we have to try and address it before making the diagnosis. Although we've already talked a little bit about what depression can look like, let's talk a bit more about what older adults experience. In particular, how does it affect your memory and cognition? People with depression generally complain of difficulty remembering. They also have a hard time concentrating. They may have a harder time watching TV or reading a story because they can't follow along. Same goes for conversations. The rate at which they can think and process and respond is also slowed. Executive function has also been found to be affected. These are the mental processes that allow us to plan, focus our attention, remember instructions, and juggle multiple tasks simultaneously. Just as an air traffic control system at a busy airport safely manages the arrivals and departures of many aircraft on a busy runway, the brain needs this skill set to filter distractions, prioritize tasks, and achieve goals, and to control our impulses. By just looking at these symptoms, it's easy to see how depression could be confused with dementia as we age. I thought this chart really illustrated well the differences between late onset depression and early onset depression. As older adults, we oftentimes have more heart disease as well as physical changes in the brain. As I mentioned earlier, executive function is more of an issue for older adults. Suicide rates are also higher for older adults than for those that are younger. We also see more apathy or a lack of pleasure, as well as the psychomotor agitation and retardation that we previously talked about. Conversely, younger adults have a family history of depression, as well as other psychiatric issues. So what are some of these changes going on in the brain that I mentioned a little while ago? In general, we find that after having a stroke, the symptoms of depression that are most common are those that are vegetative, meaning slower or less responsive. After a significant life event such as a stroke, it's common to find that older adults show slowing of mental and physical activities, a lack of interest, low initiative, slower thinking speeds, low motivation, sadness, low insight, or a knowledge of what's going on with their individual's health, and decreased function. So it's easy to see why many patients appear to have depression or dementia after a stroke. And in fact, studies show that 1/4 to 1/2 of all patients that have had a stroke would meet the criteria for depression. Interestingly, studies show that patients with Parkinson's disease have milder depressive symptoms, and they have less difficulty achieving pleasure, which we call anhedonia. Studies also show that cognitive dysfunctions arise from areas of damage in the frontal and subcortical regions in late onset depression. So this means that there are changes ongoing in the brain that actually may predispose us to depression. So which older adults are most at risk for depression? Those with hearing loss. Studies show that adults that use hearing aids have lower rates of depression. So improving our hearing might actually improve these symptoms. The death of a spouse, friends, or family members. The longer we live, the more we experience the loss of those close to us. Many of my patients mention that their close friends or family have all passed away and they have no one to really socialize with. Moving out of your home is an example of a major life event that most older adults are not in favor of or haven't really planned for. Some medications have been associated with developing or worsening depression. The more medical problems we have, the higher risk of depression. The risk of depression also increases with age. Based off of studies, more women are affected by depression later in life than men, probably because they live longer. Again, not having a lot of socialization can absolutely increase the risk of developing depression. So those that live alone or are divorced are at a higher risk. Low education level. Those that are already experiencing changes in thinking and memory. Current or past use of tobacco, alcohol, and drugs. And studies also show that recurrence rates of major depressive disorder are higher in late life depression. So if you've had depression earlier in life, you're more likely to get it as you age. I want to take some time to illustrate how significant of an issue depression is in older adults. Minor depression is characterized by having some, but not all of the diagnostic criteria we mentioned earlier, but it's still negatively impacting the person's life. With minor depression, there's a lot of a variability between how much we find in outpatient settings, 8 to possibly more than 40%. This is partially because of potentially how hard we're actually looking for it, but also because it's very easily missed. The reason it's important to look for minor depression in older adults is that it's highly associated with disability and poor health outcomes, including a higher risk of death. When we look at rates of depression in older adults, we see that moving from the outpatient to a nursing home essentially doubles the prevalence of depression. Many older adults, while hospitalized, may also have depression, which can continue after they've been discharged. Late life depression, related to the presence of medical diseases or states and cognitive deficits, is also more strongly associated with negative outcomes. There's also an increased risk of suicide and overall mortality. This means that older adults are more likely to attempt and be successful with completing suicide. The COVID-19 pandemic has also significantly impacted our emotional and physical health. In March 2022, the World Health Organization indicated that depression has increased by 25% across the globe as a result of the COVID-19 pandemic. Multiple studies show that depression rates among older adults increased both during and after the COVID-19 pandemic. So let's get to what I'm guessing a lot of you came here today to learn about. Are these changes dementia, depression, or both? It's not really an easy question to answer. Studies show that major depression increases the risk of developing dementia, especially Alzheimer's, especially when the patient notices some cognitive changes or the dementia has been diagnosed. Patients with major depression and mild cognitive impairment may have difficulty in performing activities of daily living. So if there are some cognitive changes ongoing, but the person's able to functionally do fine, if you add depression into that mix, their function might be impaired, so they'll look like they have dementia. And here's some examples of the cognitive deficits in patients that we see with depression. Executive function, which we talked about. Verbal fluency, which is the retrieval of information from memory. Tests we'll do for this in the clinic include recalling words from a category, such as animals, or can be tested by having someone remember words that begin with a certain letter. Episodic memory, which is the long-term storage of information, as well as the experiences or context surrounding them, such as time, location, and the emotions experienced with that memory. In general, with dementia, our long-term memory is more preserved. So if someone's having a hard time remembering the past details from long ago, this can be a clue that depression is present. Sustained attention, which you talked about, is also concentration. We often use time tests in our to evaluate for this. Same thing with processing speed. Working memories first. Working memory, which is a limited storage system that can hold information temporarily, such as for using cognitive tasks. There's some debate about this, but we generally call this our short-term memory. Processing speed, or how fast your brain works. Again, we use some time tests to evaluate this. We know that chronic depression throughout life increases the risk of developing dementia. However, depression symptoms late in life may also be the start of dementia. So in the end, it's very difficult to determine whether depression precedes or has started after the cognitive changes start. It's a bit of a chicken and the egg situation. So one of the reasons I discuss depression so frequently with my patients is just that. It's so difficult to tell whether something's depression or dementia. And it also may be difficult to discern if depression's there at all. As we talked about earlier, minor depression is very easily missed. So, very often we talk about treating depression even though we're not quite sure if it's there. There are many medicines that we can use to treat depression, and some are safer to use in older adults than others. We generally choose medicines that have a lower risk of side effects in older adults. Some examples include sertraline, citalopram, escitalopram, and desvenlafaxine. You'll notice some of these medicines are highlighted in red. These are medicines of the SSRI class, or selective serotonin reuptake inhibitors. These medicines have lower sedating side effects, which is ideal for older adults. In the clinic, I'd find that using these medicines produces a more significant improvement in quality of life than the medicines we actually have to treat dementia. Our large studies show that clinical improvement in symptoms from using just one medicine for late life depression was low. However, when a new medication was started in place of the old one, or another medicine was added on, the people who didn't have a good response from the first medicine had a much improved response. So in short, there's a bit of a trial and error when it comes to picking the right antidepressant for the right person. As I mentioned earlier, it's important to talk with your medical provider about the risks and benefits for any medicine you're looking to start. So what are other options that are out there if we don't want to take a medicine? Therapy is a long-standing and very effective treatment for depression. Some types of therapy include behavioral therapy. This type of therapy works best when there's a behavior that's negatively affecting the person. And the goal is to teach people new behaviors to minimize or eliminate the issue. Cognitive behavioral therapy. This helps you to become aware of inaccurate or negative thinking, so you can view challenging situations more clearly and respond to them in an effective way. Cognitive bibliotherapy. This is where the participant tries to improve their life by obtaining information, support, and guidance in the form of reading books and stories. Problem-solving therapy. This provides patients with the tools to identify and solve problems that arise from life's stressors, both big and small. Brief psychodynamic therapy. This focuses on clients' self-awareness about the unconscious processes that have affected past and current behaviors. And finally, life review therapy. This is literally just reminiscing about the past. And this in particular has been shown to be very effective for older adults. There have been reported benefits with the use of electroconvulsive therapy, or ECT, which is being used more and more in older adults with good effect. We must be cautious with this treatment, however, because there are side effects in older adults. Repetitive transcranial magnetic stimulation is a newer treatment being studied and developed that appears to be as effective as antidepressant medications in treating depression in older adults. This involves implanting a receiver in certain areas of the brain, which can be turned on and off by an external magnet. While this sounds very science fiction-y, it's being used to treat a number of neurological diseases today. I want to take a little time to talk about some of the other mood disorders. Many of us experience anxiety frequently. However, people who are diagnosed with generalized anxiety disorder worry more than the average person does about everyday things, and it negatively impacts their quality of life. In order to diagnose, we look at these symptoms: feeling keyed up or on edge, tiring easily, trouble focusing, irritability, feeling tense, and trouble sleeping. So you'll notice I've highlighted some of these symptoms in red. We again see that there's a bit of an overlap between depression and anxiety in terms of symptoms, which makes sense because we often use antidepressants we talked about earlier to treat anxiety as well. Panic is a much severe form of anxiety. Sometimes the panic attacks happen for a reason, like being out in a busy public place, or can happen out of the blue. There must be at least 4 of these symptoms on the right here in order to diagnose panic. You'll notice that these symptoms can look very similar to serious medical problems, like having a heart attack. So it's always important to report